and the Secretary General of AIDS Society of India. I'd like to request them to carry forward the next session.
Good morning, everybody. I think the hall is becoming populated now. At the outset, let us thank the organizers for arranging this clinical presentation session. And on behalf of both of us, Dr. Murugesh and myself, we invite you to a session in which we have a variety of papers being presented, right from clinical profile of cases which belongs to the epidemiology scenario to the level of drug toxicity. And without wasting time, I think we'll start the presentations.
Hello. Can I call upon the first speaker, Dr. N. Pawar from Pune? I request to stick on to the time, madam.
Chair and delegates. I'm Dr. Nivedita Pawar from Pune. First of all, I would like to thank conference organizers for giving me opportunity to present my data. Today I'm going to talk about decline in calculated creatinine clearance after tenofovir initiation among patients attending program clinic in Pune. As per 2015 estimates, there are around 2.1 million HIV infected individuals in India and around 9,55,000 patients are taking ART at more than 528 ART centers by June 2016. Our national ART guidelines evolved over years with respect to ART regimen and CD4 cutoff for ART initiation. The CD4 count cutoff for ART initiation was changed to 500 cells per cubic millimeter in July 2016, which was previously 350 cells per cubic millimeter. The preferred regimen for ART was changed to tenofovir lamivudine efavirenz from zidovudine lamivudine nevirapine in 2014. A single pill FDC of TLE was recommended for various reasons like reduced pill burden, good adherence, safety in pregnancy, efficacy against hepatitis B, etc. Currently, all new patients are initiated on TLE-based regimen. So we all know that tenofovir is efficacious and safe, but it can cause nephrotoxicity, which can be acute tubular necrosis, Fanconi syndrome, irreversible renal damage if continued to be used in spite of nephrotoxicity. Some patients have high risk of nephrotoxicity if they have a low CD4 count, low body weight, other comorbidities like diabetes, hypertension, higher serum creat levels at baseline, and concomitant use of nephrotoxic drugs like NSAIDs. And vast history of renal problems like renal calculi and obstructive urethra. Whenever required, program to use Cockcroft-Gault formula to calculate creatinine clearance, and dose adjustment of tenofovir can be done if calculated creatinine clearance is low, as per this chart. And there are multiple studies conducted across the world about tenofovir and its safety. These are few major studies conducted in India, which also showed there is a renal dysfunction associated with tenofovir. So objective of our study was, most of these studies are conducted in private setup. That's why we wanted to generate a data from government program clinic, and objective of our study was to study the change in calculated creatinine clearance after tenofovir disoproxil fumarate based regimen ART initiation among patients attending program clinic at Nari ARTC in Pune. Basically, this was a retrospective study conducted between July 2012 and July 2016 at ART Central National AIDS Research Institute. Patients having at least 1 yearly follow-up of serum creatinine were included. Those who were substituted to tenofovir and newly initiated on tenofovir-based ART were included in the study. All patients were managed as per national guidelines, and their laboratory, clinical, and demographic data was collected from patient white cards. Serum creatinine was measured at baseline and every 6 months, and for this particular analysis, we have considered yearly serum creat values up to 3 years. Patients having missing baseline creatinine values were excluded, and glomerular filtration rate was measured by Cockcroft-Gault formula. Statistical analysis was done by Wilcoxon sign rank test to calculate the significance for change in creatinine clearance from baseline at all visits. So there were total 634 patients, out of which 55% were females, median age was 40 years, median CD4 count was 324 cells per cubic millimeter, median weight was 50 kg, median serum creatinine was 0.61 mg per dl. So here in this table, we can see that around 77% patients were aged between 31 to 50 years of age, and 47.3 patients had their CD4 between 101 to 350 cells per cubic millimeter. 57 patients, that is 8.9%, had TB at baseline, and 2.8% patients had diabetes mellitus, 2.1% patients had hypertension at baseline. So median GFR by Cockcroft-Gault formula was 105.5 ml per minute at baseline, and year 1 it was 91.3 ml per minute, at year 2 it was 86.0, at year 3 it was 72.3. So the change in creatinine clearance from baseline at all visits was significant. Overall, 59 out of 634 patients showed a decline in calculated creatinine clearance below 50 ml per minute, of which 49 were asymptomatic, and their all investigations were within normal limits. Hence, they were continued on tenofovir daily regimen under close monitoring. 5 patients had serum creatinine more than 1.3 mg per dl and creat clearance less than 50 ml per minute. They were referred to nephrology OPD of Sassoon General Hospital for further management. 2 patients were changed to AZT and abacavir based regimen. As I mentioned earlier, these are few studies conducted in India previously by Mitra et al. And Patel et al. Published before. They have concluded that tenofovir nephrotoxicity can be mild and reversible, and incidence is low. This data from program clinic, where the decline in estimated creatinine clearance was observed in patients on TDF based regimen. Some patients with a low creatinine clearance were improved on their body weight following ART or recovered from dehydration, and creat clearance also improved. Creatinine clearance should be carefully interpreted in patients with a normal serum creat. Otherwise, patients having low body weight will have calculated creatinine clearance less than 50 ml per minute and will require dose adjustments. There are certain limitations to our study, that we have considered patients with at least 1 yearly follow-up. We have not considered transfer out patients. Though ultrasound and urine reports were routinely done, they were not systematically recorded in the program database. Follow-up investigations on blood sugar and blood pressure monitoring was not done in all patients during follow-up visits. So the number of patients with comorbidities may have been underestimated. We did not consider data for comparison in patients on AZT and PI-based regimen. And here I would like to conclude, though there is a decline in kidney function, it was within a range of normal function for majority of patients, and long-term multicentric studies with systematically collected data should be conducted in ART centers, which will be useful to document the TDF-related toxicities. Thank you.
Thank you for bringing out the extensive observation on your nephrotoxicity on your patients on tenofovir. And almost everybody sitting in this hall will share the feeling that as we are using more and more of tenofovir, nephrotoxic effects are being visible in most of the centers, and the increase in the number of patients who are affected by nephrotoxicity of tenofovir is definitely going to be more and more as we are going to use it more and more. But I'm surprised, there's a significant amount of dropouts as the year passes, and that's quite, higher than what we would anticipate, from a high value of 600 plus to almost 200 plus at the end of 36 months. And you have noticed that some of the investigations could not be done on follow-up. I can't understand why they could not be regularly done. And the other thing perhaps which I would like to highlight is that because we are seeing more and more of nephrotoxicity, and there are so many centers in India perhaps where proper nephrology care may not be available, it may be that these patients require more regular renal function assessment than once in 6 months or so. And it's not very expensive and should ideally be practiced more frequently.
I think even the creatine and creatine clearance, everything should be documented. You did a retrospective study.
Yes, sir.
That's what documentation should be done, so that you can, further people can, in future people can take a reference. Any questions?
I think it is well-known fact that all literature shows that TDF can cause creatinine problems or kidney problems. I think it's a better study if you compare with other normal persons, other regimes, for example. So it's a more value for study if you got to compare the AZT regimes or ABACR regimes. Then your comparison will be there. But other drugs may also can cause, maybe little bit can cause a problem with the kidney problems. So other drugs also may respond for the same. So if it is possible, you can take that other patients for the comparison of other groups.
Thank you, sir. Thanks for your suggestion.
Good presentation. I was wondering whether you did any phosphate levels on these patients, and also simple things like, I'm not sure whether it's done here, urine albumin creatinine ratio.
Ma'am, we usually don't do urine phosphate at our clinic, and urine albumin can be done, but usually normal urine reports are not recorded in cards. That's why we couldn't collect data.
Thank you.
That's a good presentation. It does re-emphasizes the importance of looking into renal functions. You also made a mention there some cases of hypertension and diabetes also were included in your study. Considering the fact these also will have an impact on the renal profile, I was just wondering, should you have considered to exclude those so that you could really say categorically only tenofovir alone has the negative impact, not confounded by diabetes and hypertension? Just
Yes,
my
sir.
observation. Thanks.
Yes, sir. Thank you, sir.
Maybe as we start looking for more and more manifestations in the future with more and more patients being on tenofovir, we must have more elaborate studies on how the kidneys are going to be affected and how frequently it's occurring in our population. Thank you very much for the presentation.
Thank you all.
Dr. Amankwa has not been able to make it yet, so I'd request the next presenter to go on stage, please.
Dr. Priyanka?
Good morning to one and all present here. My name is Dr. Priyanka B. Aglave, and my topic of presentation is impact of psychotherapy on stress level of HIV positive menopausal sex workers and interventional appraisal in a rural panorama. We have selected this topic because the number of HIV positive sex workers in different talukas of Wardha district is increasing day by day. There are many studies related to menopausal problems, hormone replacement therapy and non-hormonal therapy during menopause. At the same time, there are studies related to problems of HIV positive sex workers of reproductive age group and antiretroviral therapy. But there are very few studies related to HIV positive menopausal sex workers and psychotherapy. So HIV positive menopausal sex workers suffer from hormonal changes, intense fear of uncertain future, and multiple stressors. Due to these three perspectives, there are changes in attitude, behavior, and hence quality of life of this section of emotionally ill-treated women fraternity. Hormone replacement therapy and antiretroviral therapy provide relief of physical symptoms, but for the psychological well-being, supportive psychotherapy is needed. So objective of my study is to appraise the impact of psychotherapy on stress level of HIV positive menopausal sex workers. This is an interventional type of study which was conducted in 4 talukas of Wardha district, namely Wardha, Devli, Selu and Arvi. This is a geographical map of all the talukas of Wardha district, but my study was concerned with only these 4 talukas. Locus of administration control was Jawaharlal Nehru Medical College, Savangi, Wardha. Locus of hormonal, non-hormonal and antiretroviral therapy was Acharya Vinoba Bhave Rural Hospital, Savangi, Wardha. This study was conducted from 1st October 2015 to 30th June 2016 on the study population of HIV positive menopausal sex workers from Wardha, Devli, Selu and Arvi. The inclusion criteria for screening was, number 1, HIV positive menopausal sex workers willing to participate in the study, and number 2, the age group from 45 to 55 years. The exclusion criteria was, number one, HIV positive menopausal sex workers not willing to participate in the study, and number two, subjects suffering from comorbid conditions of hypertension and diabetes mellitus. The sample size was 88 and the study design was as follows. Firstly, approval from the Institutional Ethics Committee was taken, after which stress level of study sample was evaluated with the help of stress scale inventory. Then categorization of participants on the basis of stress level was done into the following three groups, that is group 1, high stress level, group 2, moderate stress level, and group 3, low stress level. Then supportive psychotherapy was given to group 1 and group 2 only by the clinical and counseling psychologist. Group 3 was excluded from the psychotherapy sessions. And the last step was impact analysis of supportive psychotherapy by clinical psychologist. Coming to observations and results, table 1 shows stress level of HIV positive menopausal sex workers. So total number of participants were 88, out of which 32.95% of participants suffered from high stress level named as group 1, 46.59% suffered from moderate stress level named as group 2, and 20.46% suffered from low stress level named as group 3. This is a diagrammatic presentation of percentage of participants in various groups. So here we can see the highest percentage of participants suffered from moderate stress level, followed by participants with high stress level, and the least in low stress level group. After assessing the stress levels and after the categorization into groups, the different number of counseling sessions were given to in various groups depending upon the severity of the stress and compatibility of the patient. So the following flow chart depicts the same. Total number of participants were 88, out of which 70 participants underwent supportive psychotherapy sessions and the remaining 18 were excluded from the psychotherapy session. So out of these 70 participants, 29 participants suffered from high stress level and 41 from moderate stress level. The high stress level group was further divided into group 1A, which required 5 counseling sessions, and group 1B, which required 4 counseling sessions. Similarly, the moderate stress level group was further divided into group 2A, which required 3 counseling sessions, and group 2B, which required 2 counseling sessions. After intervention of psychotherapy, modulation in stress levels were seen. So this table summarizes the data in the previous flow chart. This is a percentage-wise distribution of participants on the basis of number of counseling sessions required. So 25.71% of participants required 5 counseling sessions, 15.71 required 4 counseling sessions, 38.58 required 3, and 20% required 2. So this table shows the modulation and stress level after intervention. So before psychotherapy, out of 70 participants who underwent supportive psychotherapy sessions, 41.43% had high stress level and the remaining 58.57% had moderate stress level. There were no patients of low stress level. After psychotherapy sessions, none of the participants suffered from high stress level, only 15.72% suffered from moderate stress level, and the remaining 84.28% suffered from low stress level. This comparative diagram shows the significant change after psychotherapy sessions. So before psychotherapy, group 1 and group 2 was at a higher range, which significantly decreased after psychotherapy sessions. Also, the percentage of participants in group 3 increased after psychotherapy session, which is suggestive of a shift of participants from high stress level and moderate stress levels towards low stress level. This is the final outcome of my study. It shows the comparative status of stress level before supportive psychotherapy session and after supportive psychotherapy session. So before psychotherapy, total number of participants were 88, out of which 32.95% had high stress level, 46.59 had moderate stress level, and 20.46 had low stress level. But after psychotherapy, none of the patient had high stress level, only 15.71% had moderate stress level, and remaining 84.29% had low stress level. This diagram clearly shows the transition of participants from high stress level and moderate stress level towards low stress level, and from moderate stress level to low stress levels. Coming to discussions, the number of HIV positive sex workers in different talukas of Wardha district is increasing day by day. Due to time and financial constraints, our study was limited to 4 talukas only because they are nearer to a locus of administrative control. Menopausal sex workers were chosen for the study because only they showed willingness for the study. Sex workers of reproductive age group neither showed willingness for the study nor for the supportive psychotherapy. Data was collected before and after the intervention and 1 month following the intervention. Primary outcome of the study was increased ability of participants to cope with stress. Secondary outcome was psychological well-being of the participants. Large sample size and follow-up studies are required to generalize the finding of the study. So keeping the objective in mind, we have come to the following conclusion that psychotherapy, if given at right time, in right manner, for right duration, along with antiretroviral and hormonal therapy, can decrease stress levels in HIV-positive menopausal sex workers and contribute to better quality of life. These are the references. Thank you.
Very good.
Thank you, sir.
Very good intervention that has been applied to them. And I'm so glad that you are bringing up newer and newer arenas into the discussion of the management of HIV-related infected people. And I would like to ask you just 2 basic questions. Why did you exclude diabetes mellitus and hypertension as an exclusion criteria in menopausal women? That would have taken away a large number of your patients. And
so we just wanted to avoid multiple therapies because already our study population was menopausal, which would be undergoing hormone replacement therapy and non-hormonal therapy. Plus the patient had HIV, so maybe on multiple antiretroviral therapy. So just to avoid multiple therapies, we excluded like comorbid conditions.
okay, but that would have included a large number of patients perhaps from your group. Okay, the second question is, what is the significance of differentiating between 2 sessions, 3 sessions, 4 sessions, etc.?
So because the counseling sessions were given based on the severity of the problem and receptiveness of the patient for psychotherapy. So it varied for different patients.
As soon as they moved from the first to the second group, psychotherapy was stopped there.
Not exactly, sir. At the most, we tried counseling them up till five counselings, and the main motto was to at least get them to low stress level group.
And your motto was mainly to study about the stress related to menopause or stress related to the HIV disease and treatment?
Basically, HIV positive and menopausal group, both of them.
Thank you.
Thank you, sir.
Hello. Good morning, madam.
Good
Madam,
morning.
you told that the groups were divided, 3 groups were made, mild, moderate and severe stress.
Yes, sir.
So, stress is a subjective phenomenon. So, on what basis these mild, moderate and severe groups were done?
Sir, we have, the study tool was stress scale inventory, which is basically a questionnaire based on 26 questions. And we had four options in it, like very often, often, sometimes and never. The very often group was given 4 points, often group was given 3 points, sometimes group was given 2 points, and never group was given 1 point. So based on these points, the total number was calculated, and there was a reference chart on which the high stress level group was from 79 points to 104 points. The moderate stress level group was from 53 points to 78 points, and the low stress level from 26 to 52 points. So based on those data, we divided into 3 groups.
Okay. Thank you, ma'am.
Thank you.
Very nice study.
Thank you, ma'am.
You had mentioned that you took approval from your ethics board. I just want to know whether you took consent from your participants.
Yes, ma'am. I mean, the study population was included only if they were willing to, and consents were also taken. The questionnaire which we had So the first page had the patient details and the consent signature thing.
Okay.
Yes, ma'am.
Second thing is, since you had quite a massive improvement, many of them went into the low stress levels.
Yes, ma'am.
Are you planning a study to see whether this is sustained?
Ma'am, this is
It'd be
like,
good to, just a suggestion, because what you've done is just at the time of psychotherapy.
Later. Yes, ma'am.
Whether you want to see it sustained over a period of time and maybe repeat your test after 6
yes,
months.
ma'am. Maybe in future we would like to keep a follow-up of the patients, but at present we did not, ma'am.
Okay. Thank you.
Thank you.
Good presentation and a new arena.
Thank you, sir.
Regarding that stress in the HIV positive menopausal woman, usually menopausal woman will have the stress.
Yes, sir.
So many physical and also regarding the future stress, sex.
Psychology, yeah.
What is the, in your finding, in your stress, what is the most commonly the people affected, whether it is in concern of future yearning or physical problem or HIV spread or difficulty in sex, what types of stress you have found and how was your counseling helps them, whether it is pointed out in some point or other?
So basically, the psychotherapy which was given to the patient was supportive psychotherapy. It is a type of psychotherapy. So our basic motto was to help them tackle the emotional conflicts or any difficult situation, to face them and to chase them. So, so sorry, your first question?
Whether they are having much about their, whether they are fearing for future, whether they are having physical illness, having sex, or whether they are having HIV prevention, in the problem regards to that. What is the type of stress more and how you tackled this through counseling? That's what my question.
Okay, so basically, normally the menopausal woman already undergoes psychological variations and she is already under stress. Plus, the patient had HIV, which is a chronic disease, and most of us know that it is like a fatal outcome. So, these two criteria added to the stress. Also, the special group was sex workers. The basic earning, to survive for them, that is the only way they can earn and survive. So, maybe due to these chronic conditions, they may end up,
Okay, good presentation. But I would like to know, as a clinician,
yes,
what exactly you are given the psychotherapy. That means only you have talked with the patients, or
yes,
you have given some treatment or medicines, and what medicines if you have given.
So
they have converted from high to low stress levels.
So no medicines were given. These were only the counseling sessions. We had a talk one-on-one with the patient.
Problem is menopause itself is a stressful condition. So
yes,
menopause can cause all these problems. That's what I'm saying.
Yes, sir.
So this is compared HIV positive versus negative. Again, comparison. That's what I want to know, because
yes,
all problem may cause because of menopause itself.
Yes, sir.
So is it HIV adding to that or not adding to that?
Yes, of course, sir, it has added to that.
But you don't have the control. That's what I'm saying.
Yeah, I think the study may have to be repeated with HIV
negative controls.
Also being evaluated
Yeah.
for the stress and all. I think it leaves a lot of scope for further studies.
Yeah.
Yes, sir. I'll keep the suggestion in mind and we'll surely try further research.
And maybe HIV positive non-sex workers, family people who are still having menopause and having problems.
Definitely. I thank Dr. Priyanka for a wonderful new concept in the management of the HIV, apart from the drugs. So it was a wonderful presentation, and thank you very much.
Thank you, sir.
Yeah, now we have one presentation from Dharwad, Dr. Nayak.
My study is on the profile of clients attending an integrated counseling and testing center of a tertiary care hospital in North Karnataka. Integrated Counseling and Testing Center, abbreviated as ICTC, it helps in preventing the spread of HIV, promoting behavioral change, and providing a range of interventions in prevention and care where clients are treated with dignity and respect. The data generated in an ICTC is extremely important and provides important clues to understand the epidemiology of disease in that particular region. I had two objectives in my study. My first objective was to study the trend in the number of clients attending the ICTC over the years. And the second objective was to study the profile of seropositive clients attending the ICTC. The present study was a cross-sectional study which was purely descriptive type, that was record-based, carried out in the ICTC of SDM College of Medical Sciences and Hospital, Dharwad. And data was collected from HIV positive clients register. That was collected retrospectively for a period of 4 years from 2012-13 to 15-16. And the data was analyzed using SPSS software. Results. My first objective is the study of trend. So this graph shows us the trend of clients reporting to the ICTC over the years. So to study the trend, I have collected the data starting from 2006 till date. So what we can see here is the blue line here shows us the trend of clients from 2006 to 2016. And the blue line shows us those clients who underwent the pre-test counseling. So there has been a gradual rise in the number of clients, starting with 1,000, reaching to 8,000. The red line shows us the number of clients who took the test. That is, all those clients who underwent the HIV testing. And the green line shows all those clients who underwent post-test counseling. So what we can see in this graph is all the three lines almost overlap, which means all those who took the test underwent post-test counseling, which is a good sign. The next graph shows us the trend of HIV positive clients attending the ICTC. So this is the trend of male clients. So starting with 2006, we can see a gradual rise till 2010-11. And since then, there has been a gradual decline in the number of clients. The same holds good for females. So initially, we have a rise followed by a gradual decline. And the green bars here show the ANC clients. The next graph shows us the trend of positivity rates. So blue line indicates the positivity rate in males. So what we can see here is starting with 2006, wherein the positivity rate was much higher, that is 30%. We have today reached a positivity rate of almost 2 to 3%. The female positivity rate, it starts with a higher positivity rate, that is 35%, goes lower down, and then reaches almost equal to that of male positivity rate. That is, over the past 2 years, the male positivity rate and female positivity rate are almost same, or you can say even females have a higher positivity rate than males. This is the ANC positivity rate touching the baseline. My second objective was to study the profile of clients. Now, to study the profile, I have collected retrospective data for the past 4 years. The profile of primary clients, we had a total of 323 males with 160 females, giving us a total number of 483 clients. The status of these clients, 68% were married, 9.5% were unmarried, 13.7% were widows, 2.1% were widower, 2.5% were separated or divorced, and 4.6% of the clients died. Co-infection with TB. We had 24 clients who were sputum positive with TB. 5 were sputum negative, and extrapulmonary were 8, giving us a total number of co-infections of 37. Spouse profile. Out of the total 327 who were married, 148 got their spouse tested. And the results, 73 of the spouse were negative. So we can call them as discordant couples, which means one of the member is positive. So further, when we studied, out of these discordant couples, majority were males. That is, almost 92% were males, and the remaining 8% were females. The rest, 75 tested positive, and this we can call them as concordant couples, wherein both the members are positive. And among these positive, we had 3 co-infections, 1 sputum negative and 2 extrapulmonary. When we saw the CD4 counts in primary clients and their spouse, the primary clients had a mean CD4 count of 257 with a standard deviation of 184, the minimum value being 18 and the maximum being 1016. The spouse had a mean value of 322 with a standard deviation of 180 with a minimum value of 34 and a maximum value of 947. When we see the age distribution of seropositive clients, the total number of clients including the primary clients and their spouse, it was around 568. Out of which 52% were in the age group of 31 to 45 years. And the second majority group was in the age group of 46 to 60 years. And we had 17 clients who were in the pediatric age group, that is 0 to 14 years. So my conclusion in this study is, out of the total tested, 99% underwent post-test counseling. The number of clients in the ICTC were on an increasing trend over years. HIV seropositivity had a declining trend. Positivity rates among males and females were almost same, or even females had a higher positivity rate. And higher positivity rates among spouse was seen. And maximum number of positive clients were in the age group of 31 to 45 years. Thank you, organizers, for giving me this opportunity.
Any questions?
Good morning. It has been very good presentation. Thinking
Thank you,
that
sir.
you have just one. I am Dr. Narendra Singh from Impal. Thank you. It has been good to learn that infection rate is coming down. Mother to child maternity infection rate is very coming down in our center.
Yes.
You have included co-infection only TB.
Yes.
And as you know, hepatitis C has been increasingly in percentage in all over the states, and also hepatitis B. Will you include this later on in your studies, or I would like to know, because your center is doing very well
Yes.
in the ICTC.
So actually, I have taken data as per the HIV positive client register, which has only TB co-infection in that.
Right.
So I will take your point, sir. I will,
Yes, thank
my
you.
subsequent study, I will add hepatitis B.
In fact, the denominators over the years have changed. The denominators are not constant over the years. That is why the trend changes are, looking so impressive. But let us take it with a pinch of salt that, the testing strategies also have changed among the clinicians, even though there has not been much change in the national level. Among the clinicians, the testing strategies have changed, and provider-assisted testing is becoming more and more common these days. And that may be one of the reasons why, some of the trends are really happy to look at.
Yes, I do agree with your
but
points.
let us think of it in a more realistic fashion and come out with better results as we analyze it more and more. So that's just a good beginning, and then I'm sure you will be able to bring out better
carry on with
data.
further studies.
Thank you. Thank you very much.
Thank you, sir.
Thank
We close.
chairpersons with a token of appreciation. Dr. R. Sajid Kumar. Dr. Murugesh Pastapur.